You are listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Valve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hi, I'm Dr. Kathy Miller. Welcome to Medscape In Discussion podcast on breast cancer and HER2. Today we'll talk about whether we're ready to begin thinking about over-treatment of patients with HER2-positive disease. Now, this seems odd at first pass. This is an aggressive form of breast cancer. We're frequently talking about how can we make treatments more effective? But we have come so far. Many are now starting to think about what don't we need to do. To talk with me about this important topic, I've invited Dr. Sara Tolaney. Dr. Tolaney is the Associate Professor in the Department of Medicine at Harvard Medical School and Chief of the Division of Breast Oncology at the Dana-Farber Cancer Institute in Boston. Welcome, Sara.
Thanks so much, Kathy, for having me.
So we have come a long way from only 2 or so decades ago when HER2 was first identified. The initial trastuzumab adjuvant trials were largely limited to those that had lymph node involvement. And I remember the arguments and the differing opinions about what to do with those that were HER2 positive and lymph node negative. And I think that's really where the concern about overtreatment got its start in the clinic. Can you remind us of the APT trial and its long-term results?
Yeah, so I think you're exactly right that we saw that trastuzumab had such dramatic outcomes for patients with HER2-positive disease, but all of those trials really focused on patients who had lymph node positive disease or larger tumors and really hadn't focused on patients who had smaller node negative cancers. And so we didn't really know what to do with those cancers. I think many were just using the standard treatments like at that time, TCH or ACTH, even in the smaller cancers because we knew trastuzumab had such significant benefits. But we all worried we were doing too much for these smaller cancers. And we knew that stage 1 cancers, for example, had more than just an insignificant risk of recurrence because we saw that people who didn't get treatment had a risk of recurrence probably on the order of 15 to 20%. And so we felt like we needed to do something, but didn't know what the right approach was. And so we had at that time designed a study we called the APT trial, which took patients who had node negative HER2 positive cancers that were up to 3 centimeters and just treated them in a single arm fashion. So we, in essence, took the ACTH regimen, but got rid of the AC. And so patients got 12 weeks of paclitaxel with trastuzumab, followed by 9 months of trastuzumab. And we just looked at outcomes. And what we saw was that we now have 10 years of follow-up. And in fact, there have only been 6 recurrences out of 406 patients that were treated on that trial. And so really, the recurrence-free interval suggests about a 97% RFI. So really very good outcomes in this population, suggesting that TH is probably adequate for most patients who have stage 1 cancers, but I think doesn't really address the question as who doesn't need any therapy for stage 1 disease. And so I think that's something we continue to struggle with, understanding which patients actually may do fine without any systemic treatment.
Well, around the time you had the results of the APT trial, we were seeing the first results in the metastatic setting with the ADC, adatrastuzumab, and tansine. And certainly in the metastatic setting, compared to standard chemotherapy with trastuzumab, this was a much more successful therapy and less toxic. And I know there was a lot of hope that that might be used in the adjuvant setting with similar benefits. That led us to the ATTEMPT trial, which I think more than anything proves why we need to put these ideas to the test.
Yeah, no, it's a good point. Even though TH was so efficacious in APT, people were still losing their hair, developing neuropathy, and we wanted to see could we develop a therapy for this population that may be less toxic, but equally efficacious. And as you pointed out in the metastatic setting, the data comparing TDM1 to TH actually suggested TDM1 had a lot less in the way of toxicity. And so we thought it was the perfect approach here because it seemed equally efficacious in that setting. And so we struggled a little bit, to be honest, with how to design such a study because one would hope you could compare efficacy between TDM1 and TH. But the challenge is when the event rate is so low with therapy, it's very hard to do a randomized study comparing events. You'd need, probably over 3,000 patients to try to prove one drug had fewer events than the other. And so we didn't really think that was feasible. And so instead we thought, well, could we just test the waters and see what the efficacy is of TDM1 in this setting, but then compare the side effect profiles between TDM1 and TH to see if TDM1 in fact was less toxic. But then the question arose is, well, how do you prove something's less toxic? What is that endpoint to say something has less side effects? And truthfully, there isn't, I don't think, a really great way to do that. And so some people would say just look at high-grade toxicities. But I think the problem is even grade 2 side effects matter. If someone has persistent grade 2 neuropathy, to me, that's a big deal. It's not just grade 3 and 4 toxicities. So we tried to come up with what we thought was a relevant endpoint, which was what we called clinically relevant toxicities, putting together things like dose holds, dose discontinuations, persistent grade 2 toxicities, as well as grade 3, 4 side effects. And we compared TDM1 to TH for these clinically relevant toxicities, but also assessed TDM1's efficacy as a single-arm approach. So enrolled 375 patients to get TDM1 and compared it to 125 patients getting TH. And so we found that the year of TDM1 was very effective. In fact, there are only 3 recurrences with 5 years of follow-up amongst those 375 patients. So really outstanding efficacy. But when we compared our clinically relevant toxicity endpoint, in fact, the total sum of toxicities for TDM1 compared to TH was really pretty much identical. But the types of side effects people were experiencing were very different. So with TDM1, for example, we gave a whole year of therapy, which I think is far too much, but it showed that a little under 20% of patients had to stop TDM1 early for toxicity. So they couldn't get through that whole year of treatment. Whereas with TH, there were a lot more people who had neurotoxicity. And so I think, in my mind, I think TDM1 is a reasonable treatment approach. Obviously, it's very efficacious. And for some patients, the side effect profile, in fact, is much better than with TH. But I can't say that it's less toxic overall, because I think a year is too much. And so we are doing some follow-up studies. We have a study now called Attempt 2.0, where we're trying to see if we can give a shorter course of TDM1, so 6 cycles of TDM1 followed by trastuzumab maintenance, and comparing it to TH for toxicities. But we've learned a lesson with the toxicity comparison that you really do need to incorporate patient-reported outcomes when thinking about side effect profiles. And so that was incorporated into this current ongoing trial.
So I know there have been some small studies looking at HER2-targeted therapy alone in the neoadjuvant setting and finding significant PCR rates, anywhere from 25 to 45%, depending on the disease phenotype. And that has led to a question of which patients might not need chemotherapy at all, might be so sensitive to the biologic therapies that that's all they need. I don't think any of us are quite bold enough to jump to stage 3 patients with that question just yet. But you are studying a biologic-only approach in the stage 1 patients.
Yeah, I think you're right that we've seen some data. So, for example, in the preoperative setting in Neosphere, you could see that trastuzumab, pertuzumab, without any chemo, had almost a 20% PCR rate. So there clearly are some patients who do very well with just HER2-directed therapy. And in fact, some data suggesting when you add endocrine therapy to dual HER2-directed therapy, you get robust synergistic activity and can raise PCR rates. And so that made us encouraged to think maybe there could be a chemo-free approach for patients who have small ER-positive, HER2-positive cancers and result in excellent outcomes. And so we decided to conduct what we call the ADEPT trial, which is a study that is giving a year of dual HER2-directed therapy with subcutaneous trastuzumab, pertuzumab, and giving it with endocrine therapy in patients who have stage 1 ER-positive, HER2-positive cancers. And it's designed very much like the APT trial was. It's really trying to show that you have a clinically acceptable low event rate in this population. So you want to see, for example, an IDFS that is 95% or higher to suggest that this kind of approach is reasonable for this patient population. So the study's enrolling and, we'll have to see what happens with the trial.
So I think it's not surprising that when we first start thinking about doing less to avoid harm and maintain results, those are questions first asked in patients with stage 1 low-risk disease. But the questions are relevant for patients with stage 2 and 3 disease as well. And we're now starting to see those efforts. Can you tell us about the COMPASS PCR trial and its companion, COMPASS RD?
Yeah, so it's exactly right. We always try to test the waters with these, what we call de-escalation strategies or optimization strategies in people of low clinical anatomic risk. But I think another way to think about tailoring therapy can be based on response to preoperative therapy, because if someone has such a good response, they achieve a pathologic complete response to neoadjuvant therapy, we do know that their chance of having a recurrence is much lower, for example, than someone who has residual disease after preoperative therapy. So you could take the approach where you could test a therapy in the preoperative setting that is not quite as toxic of a regimen. And if someone has a PCR, well, that was enough for them. They don't need to get more chemo, and we can see if they have good long-term outcomes. Whereas if they have residual disease, maybe that's someone who actually needs to escalate therapy and do more. And so that's kind of the strategy with the sister trials, if you will, the COMPASS PCR and COMPASS RD study, where with COMPASS PCR, they're taking 12 weeks of a taxane with trastuzumab and pertuzumab. And if you achieve PCR, you just go on to complete the year of HER2-directed therapy. You don't go on to get any further chemotherapy. Again, suggesting that if you had PCR to just 12 weeks of chemo HER2 treatment, you're likely going to do well and probably don't need more treatment. And so that's really being conducted in a single-arm fashion, really trying to look at relapse-free survival in that setting to see if there's a clinically acceptable event rate to suggest that that is a good strategy for people who achieve PCR to THP. Whereas COMPASS RD is taking an approach where they're saying if you got 6 cycles of preoperative therapy or 6 cycles in total of chemotherapy and had residual disease, then you can escalate treatment. So normally we'd give TDM1 to someone who has residual disease based on Catherine, but in the COMPASS RD setting, they're looking to see if you could add tucatinib to that TDM1 to see if we can improve outcomes. We have some data to suggest that TDM1 and tucatinib can be synergistic. And so the hope would be that it would help prevent recurrences. But also, I think the hope is that tucatinib does penetrate the CNS. And, I think one disappointment in Catherine was we did not see a reduction in CNS as the site of first recurrence with TDM1. And so maybe adding tucatinib could also potentially help us there. And so I think a really unique set of trials trying to use response to PrEP therapy to help tailor to that individual patient.
So, Dr. Tolaney, when we talk about the ADCs, we have to talk about pneumonitis. This, to me, I think is both an important toxicity, but I'm beginning to feel like it's one that we talk about way more than we might need to. How do you follow patients for pneumonitis? How actively are you looking for that trouble?
Yeah, I think we've all seen the tremendous benefits of trastuzumab deruxtecan for our patients who have metastatic HER2-positive breast cancer, where I think it's really revolutionized outcomes for these patients. But as you point out, we know that 10 to 15% of these patients will develop interstitial lung disease, and we're seeing about a 1% death rate from ILD with this drug. And so I think we do take the ILD with T-DXd quite seriously because of this potential risk of death that is associated with the drug, even though, again, quite rare and becoming, I think, less and less common as we understand how to utilize this agent. but nonetheless, I think does require careful monitoring. And so, in the original trials where T-DXd was studied, we did scan patients every 6 weeks. So very often, much more often than we would traditionally do so in a patient with metastatic disease for restaging. And I think the thought is that it may be if we're screening more often, we'll catch interstitial lung disease at a very early time point. Because with T-DXd, you do have to discontinue the drug if someone develops symptomatic ILD or grade 2 or higher ILD. So we all hope that if someone gets ILD, we catch it when it's just grade 1 so that we have a chance to retreat them with it. And so I do typically re-image my patients every 6 to 9 weeks, which is quite often because I'm very cautious about monitoring for ILD. But the truth is, we don't know if that's necessary. It's not that someone's compared every 6 to 9 week imaging to every 12-week imaging to show that rates of high-grade ILD are less frequent. So I think we just don't know what the optimal way to monitor is. We don't know if we should be incorporating PFTs into this. And so there are lots of studies actually that are ongoing trying to better understand if we can predict ILD or if we can catch it at earlier time.
Do we have any information on which patients are at greater risk of developing ILD?
Yeah, so they had done a really nice meta-analysis of the patients who had received T-DXd in the early setting across diseases. And some of the signals that they found that were associated with higher rates of ILD were being of Asian ancestry, where they saw that people of Asian ancestry did have a higher rate of ILD. Having renal dysfunction was associated with higher rates of ILD. Getting higher dose of T-DXd was also associated with higher rates of ILD. And so I think those are things that I certainly think about as potential risk factors. But I think we also have to realize that having underlying pulmonary metastases, for example, does not mean that you're at higher risk for ILD. And so that's certainly not a contraindication to getting T-DXd.
I have one last question for you, Sara, and it really stems from my clinic experience yesterday. I realized as you were talking of the patients I cared for in my clinic yesterday, 4 of them had had metastatic HER2-positive disease for more than 10 years and were continuing therapy. Do you ever worry about overtreatment in those with stage 4 disease?
It's crazy how things have changed. I think with metastatic HER2-positive disease, we really have seen such a tremendous increase in outcomes to the point where we do wonder if some of our patients actually may be cured of their metastatic disease. And so I think this scenario comes up, for example, in patients who, let's say, got induction therapy with THP for first-line treatment, maybe went into a complete response and went on to dual HER2-directed therapy as maintenance. But 10 years later, maybe they're still in CR and you're wondering, does this patient actually need to be on HER2-directed therapy? Have they been cured of their cancer? It's been many, many years and we've never had a problem. Can we stop the HER2-directed therapy? Are we just causing side effects? And I think we're also nervous in that scenario to pull back because they had documented metastatic disease and we obviously don't want that disease to recur and come back. And so I think we've all usually just continued the treatment. But there is a study ongoing called Stop Her, which is taking people who have been on HER2-directed therapy without any disease progression for at least 3 years and stopping that treatment and looking at outcomes. And, I think we'll have to see what happens with that study. But I think even more importantly, that study is going to look at circulating tumor DNA and assess if minimal residual disease may be a strategy that could help us figure out if there are patients who could stop their HER2-directed therapy. So I think we need to learn more, but I think you're right that we do worry about over-treating these patients who may not need further therapy.
Well, today we've been talking to Dr. Sara Tolaney about treatment of patients with HER2-positive disease, really beginning to individualize who gets what. Less therapy for those patients who have smaller tumors and are likely to have a very good prognosis, but more therapy for patients who still had residual disease after neoadjuvant treatment. It's been a really exciting 2 decades in HER2-positive disease with dramatic changes in what we can offer our patients. Thank you for tuning in and joining us. And please take a moment to download the Medscape app to listen and subscribe to this podcast series on breast cancer and HER2. This has been Dr. Kathy Miller for Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.